Dr. Norton is an assistant professor in the Division of Pediatric Infectious Diseases and Immunology at the University of Minnesota Medical School, and she has been terrific in agreeing to moderate this panel. And she's going to ask the panelists to introduce themselves, so I'll turn it over to Laura.
Okay. Can you hear me? Okay. All right, so yes, first we'd like to start with introductions. If we could just go down the line and have you tell us your name and your affiliation and just briefly describe your role in stewardship in your facility, including the type of care setting and then your role in stewardship outside of your facility, if that's applicable to you. So maybe we'll start at the end.
Hi, my name is Brooke Schug. I'm a clinical pharmacist at Abbott Northwestern Hospital. I primarily work in the emergency department where I do participate in helping implement our stewardship-led policies and recommendations. I have experience in stewardship at hospitals as well in California, where I started a stewardship program at California Pacific Medical Center in San Francisco. And then I also participated as a stewardship pharmacist in Highland Hospital in Oakland, California.
Good morning, I'm Roberta Meyers. I'm an internist and a geriatrician at Hennepin Healthcare, which is HCMC and the outlying systems. I'm a geriatrician, so I'm primarily in outpatient settings, long-term care settings, and clinic for my practice. My other role at the medical center is in the Office of the Medical Staff, where I do some work with quality in the EHR, and I'm familiar with the inpatient antibiotic stewardship program in that role.
Good morning. I'm John Hallberg. I'm a family physician at the University of Minnesota, and I practice 5 to 6 days a week at a small clinic called the Mill City Clinic. And we take care of everyone from 1-week-old babies to, I think my oldest patient is 98 years old. And I'm the medical director, and in that capacity, I oversee a lot of the quality measures in our clinic, including antibiotic stewardship.
Hi, Jeff Gerber, Children's Hospital of Philadelphia. My inpatient work is in immune-compromised hosts, where I direct the Antimicrobial Stewardship Program, and I do research on both inpatient and ambulatory stewardship.
Okay, great. So we have a few questions prepared by the organizers that they want us to cover, and then we're going to open it up to you guys for questions as well. So to start, if you guys could let us know what specific stewardship interventions you've implemented at your facility. So for example, do you track and review antibiotic use? Do you use watchful waiting protocols or prescribing guidelines? And then any challenges that you've encountered in implementing stewardship strategies at your facility?
So some of the interventions that we've implemented at our facility include, I specifically work in the ED, so we have ED smart sets that our electronic system utilizes that will help direct physicians to the commonly prescribed reasons for prescribing antibiotics, to what the guidelines are currently suggesting, as well as taking into account our antibiogram. We can track that it's been used in all of our hospitals and clinics, but we are currently not saying or giving feedback to anyone whether if they're using it appropriately or how they're using it. It's not a recommendation of whether they do use it or not, so you can still freehand in any antibiotics that you would like. And we do track days on therapy for our inpatients, and it's currently being developed to track it for our outpatients as well in the clinics.
At Hennepin, the biggest success in antibiotic stewardship has been inpatient, and I think one of the challenges is trying to carry that over into the outpatient setting. A lot of the resources go into the inpatient setting for a variety of reasons, but we do track antibiotic use and ordering in the inpatient setting pretty heavily. The biggest success we had in 2017 was reduction in catheter-associated urinary tract infections in the inpatient setting, and that was through monitoring and feedback of both Foley catheters and the ordering of urine cultures. And it seems like those two interventions played the biggest role in reducing CAUTI. So likely there weren't as many CAUTIs as we thought, and if we took catheters out or if we eliminated cultures, we somehow people survived, patients survived, but that was a big monitoring push. We do have a very active antibiotic stewardship committee, but they have trouble getting traction in outpatient settings. I think that's a challenge for our organization. As a geriatrician in long-term care, the professional societies in long-term care have been very active in antibiotic stewardship from an educational and promotion standpoint around the use of antibiotics. So not necessarily associated with my organization, but with my professional career, I think in long-term care there's been a push. But ambulatory, I think, is still a little bit of a challenge, in my career at least, for antibiotic stewardship.
Well, as a perfect segue, I'll echo that. As someone who's in a small clinic, I have 7 colleagues that see patients, but we only account for about 2.3 full-time equivalents, so FTEs. And we have kind of co-location, so we sit side by side with our RN nurses who are often receiving the phone calls from worried parents or people thinking that they're suffering from something that might require an antibiotic. And truth be told, I'm at the University of Minnesota, but in the outpatient setting, we do not have a formal sort of stewardship program in place. We use Epic like a lot of the groups use. I joke that we have the Yugo version of Epic, if anyone remembers the Yugo car. It's a little less robust than it should be. So we don't really have the capability to dig into it as much as we would like. And there's so much effort or emphasis on my part to look at a lot of the community measures for depression, cardiovascular disease, diabetes. Frankly, that's where a lot of our focus has been. So I'm almost a little embarrassed to say that, but that's the reality. That being said, being in a primary care clinic, I think that we always think about why patients are coming to us, and a lot of times it's fear and pain. And if we can have a good relationship with our patients and figure out why it is that they're there and what they're worried about and ask them what they're, really what's at the root of their concern, a lot of times you can treat the symptoms and it doesn't require an antibiotic. And so we've gotten very good at being creative with how do you relieve sinus pressure, symptoms, and pain without an antibiotic. Many UTIs are not UTIs, it's pain for another reason. So that's really become a big part of what we do. And we have made use of what we affectionately call WASPs, so wait and see prescriptions. So actually giving a prescription to a parent or someone, and in our overwhelming majority of times, it's never filled. But it's Friday afternoon, they don't want to spend another copay, they don't want to go urgent care on the weekend. And a lot of times when we check in with them on Monday morning, they never got it filled. But they were happy to have that in hand in case they needed it, but it turned out they didn't need it.
So I talked a lot, I'll start with outpatient. I talked a lot about that. The outpatient intervention, the peer comparison audit feedback that I showed you as a research project, we've turned that into a QI project. So although we don't have a formal outpatient stewardship program, we do have we use a tool called ClickView, which is, I don't know if everyone's heard of it. It's kind of like Tableau or sort of like Excel on steroids, where you can point it at lots of data feeds, and in real time it will show prescribing. So all of our outpatient providers can see in real time how they compare to peers, and now they're all above 90% first line prescribing. But we have work to do though, and that's just for choice of antibiotics. On the inpatient side, we are pretty aggressive, although most programs use prospective audit with feedback. We're a heavy prior authorization program. So 40 of the 60 antimicrobials that we have on formulary all require prior authorization. We use Epic. You can, with a click, if you click the right indication, you can get 48 hours without talking to a human and asking for it. But after 48 hours, that antibiotic will fall off. So every antibiotic order has a stop date on it, and so an end date. And so if you need it beyond 48 hours, you have to call and then get approval, and you'll get approval from one of our we have 2 full-time clinical pharmacists who are ID trained, and then we have 9 clinical fellows who take the pager off hours. And if you need more, you can get, say extend it to 7 days, but that 7 days will have an end date on it. So that's how we manage it in the inpatient setting. Another tool that we use, I mentioned ClickView, just like the outpatient side, we use that to show overall antibiotic use and by unit on the inpatient side. And we've developed an automated electronic antibiogram, which is what we think more helpful, we think is a little bit more clinically relevant, where it's sort of syndrome based and separates. So we used to get this antibiogram from our clinical pharmacy, from our micro lab that was just like, every E. coli that had ever been isolated in the hospital. And, you're mixing, catheter urine from a bone marrow transplant patient with the results from a kid who's 5 years old and has never had and has a community onset UTI. So we now have an antibiogram that shows the antibiogram for a community onset UTI, pus from an abscess in the community versus blood cultures from the cardiac intensive care unit. And we're hoping that that can help, guide empiric selection. So those are a few of the tools.
It sounds like everybody has pretty robust inpatient programs, but we've all identified that we don't have formal outpatient programs, or that's an area where there's a need. Do you think, are there specific barriers? Dr. Hallberg, you mentioned, competing priorities or other things that are capturing your time. Are there specific barriers, or it's just been lack of time?
Yeah, lack of time, and I just think prioritization. I mean, I think all of you are well aware of the fact that I think that the opioid crisis has sort of leapfrogged this, and in fact, I often think that the success of antimicrobial stewardship, broadly speaking, has been very successful in the sense that I find so fewer patients are asking me for antibiotics now. So I think they've gotten the message, and I think that if there's something good out of the opioid crisis, it's been that medications have consequences, and I think that for so long have just thrown pills at people for all kinds of reasons, right? It's the simplest thing to do, give someone a prescription, high patient satisfaction, you've gotten to yes, everyone's happy, and then suddenly we start realizing that fluoroquinolones like Cipro are now getting a black box warning for causing neuropathies, especially when associated with things like prednisone. And people who went in for a sinus infection suddenly can't walk. And so I think that we're finally waking up to that. So I think that the national conversation has been terrific. There is still work to do, and I think that, I know in my case, we're just still struggling with depression, cardiovascular disease, diabetes, just colon cancer screening, just trying to get that stuff sort of harvested from the electronic record. That's really, unfortunately, in my case, especially taken in the forefront, unfortunately.
And I might echo that. I think healthcare organizations seem to be responding to external pressures. So if you can think of an external pressure that would drive outpatient antimicrobial stewardship, the moral high ground's harder. Although I think I think changing the culture is important, and there are other ways to do that. To really get hospitals to commit resources, it requires a external pressure with a stick.
Yeah, so speaking of external pressures with a stick, so our hospital has recently signed a contract with Aetna, which is the major insurance provider in our outpatient practices, that will provide, this is a carrot, not a stick, will provide bonus payments if you're meeting certain recommended metrics. So, and appropriate antibiotic prescribing is one of them. So some of their bonus payment, it's either a carrot or a stick, because they expect a certain bonus payment, and you won't get all of it, I guess, if you don't adhere to that. So that's one thing you can do. And insurance companies are motivated because broad spectrum antibiotics cost more money than narrow spectrum, 3 to 5 times more expensive. So insurance companies can be a partner there. And I would add to the opioid, I think the comments about the opioid epidemic are really salient. And, I think and thinking about Epic, and I think all versions of Epic are the Hugo version, because Epic is a billing system to make money, and it's not really great in terms of clinical decision support. But leveraging your electronic health record to make it easier for the doctors to do the right thing is a sort of a behavioral economics principle. I was talking about that before. There was a talk that I saw the other day from an emergency department researcher at Penn, where they were trying to reduce opioid prescribing. And what they found is that the order sets in Epic for post-surgical opioid prescribing, your ACL repair, it would always default to 30 days of medication. And then they asked the surgeons, and they were like, I don't need 30 days. And then they called patients, and they found out that most of the patients, some weren't taking any, and the ones who were taking a mean of like 3 to 5 days. So they just changed the default from 30 days to, I think, 5 or 10 days, and they cut opioid dispensing by 60-something%. So thinking about making it easier to do the right thing, and around antibiotic prescribing, if you have an order set, and in pediatrics, it's otitis media, strep throat. If you put that diagnosis in, and what pops up is the first line recommended drug, narrow spectrum drug with the right duration, and you make it harder for them to have to go and give them, 10 days of Omnicef, that's a really, pretty low hanging fruit way to go after it.
Dr. Hallberg, you mentioned that you find fewer patients asking for prescriptions, and I think that's great, but I think that prescribers are still finding it challenging to communicate with patients and families about judicious use of antibiotics. Are there specific strategies that anybody has found to be successful, including any specific language that you use?
I think something as simple as strep throat is a good example. So we do a throat culture. It's positive for group A strep and beta hemolytic strep. And I remind people that the reason we're prescribing the antibiotic is not because their throat hurts. Ibuprofen's probably going to help more for that. It's because I don't want them to get rheumatic fever. It's really the consequences of it. And so I think a lot of times having that conversation, I have a little laminate that I show of the face. It shows where all the sinuses are and sort of describe, like, if you have a boil on your back, I can give you all the antibiotics in the world, but that's not really going to help the boil. We've got to lancet. We've got to get rid of that pus. And so using neti pot, using Flonase nasal spray, using saline irrigation, sort of explaining things is really effective. Women who think they have a UTI and it's not that, and it's more of an irritation, reminding them of that. And so not everything points to the need for an antibiotic, and just reminding people of that. It takes a little time, but I think in primary care, it's one of the things we excel at is that sort of long-term relationship and the communication, and hopefully having time. Although I know primary care we have time pressures, but it's so worth it to take that extra step to explain things.
So part of what we do at Hennepin is train medical students and residents, and one of the things we train is a mnemonic called MEET. We monitor, evaluate, assess, and treat. That's what we're doing in our encounter. And I think trying to refocus the value on the evaluation and the assessment, even for the provider, is useful so that you can kind of recap an encounter and say, I've heard you to the patient, I've evaluated you, I've assessed you. Part of our treatment is just going to be to wait, to not use an antibiotic. I'll monitor you. Somebody will check in with you tomorrow so that we can do the M, the E, and the A, and maybe the treat we just hold off on. Of course, the patients want the treat. Interestingly, residents want to also treat. They want action. They want to write a prescription. They want to make the diagnosis. But I think if we sort of redirect to the monitoring, evaluating, and the assessment are very important parts of an encounter, and put the value back on that, you can steer the conversation a little bit away from the big T that everybody wants to get to. And that's a culture change. So I think that starts just with reminding people what they can get from coming to the doctor. And it's not always the T.
At Abbott, we have a collaborative practice agreement in the emergency department, so the pharmacists are actually the ones who follow up on all the cultures that are drawn in the emergency department. And I think our biggest challenge is asymptomatic bacteria. If a culture comes back positive, we still do have to call the patient, tell them there was a positive result, and walk through that with them to decide whether we need to treat or not. And so I think what you mentioned is it's more time consuming. It's way easier for us to just prescribe the antibiotic. For our group A streps, we only see the reflex cultures, so if it's the rapid's positive, it doesn't come to our queue, but we'll follow up on all those reflex cultures. And it's way more time consuming to walk the parent through the usual time course of how long strep lasts versus, now you're on day 5 or 6. It's most likely going to be, self-resolved at this point. And then any abscess cultures that do come back positive for something, but yet we've already, IND'd it, and that's really the treatment of choice. I think a lot of it is just educating the patients, but also when they hear that something was positive, it sounds a little bit scarier. So I think it's good to give them the information and follow up, but it is a lot more time consuming, and that's challenging for us, I think.
Okay, one more question before we open it up. Have any of you engaged in stewardship across care settings? So for example, patients moving from, Brooke, from the ED to the outpatient. So you talked about a few things that you're doing, or from inpatient to long-term care. Dr. Meyers, any?
So don't get me started about the transition from ED to long-term care. I wouldn't necessarily use the word stewardship. You know, it's really hard because the ED looks at things differently, and they feel so compelled to treat a positive urine culture. So we stop some of their antibiotics. I mean, it's hard to get them not prescribed, but in long-term care, we will stop those antibiotics. So it's just and I think it's well-meaning practice on both sides. It's just, again, it's the value of we can monitor and not necessarily treat, and the world will not end. They're going to long-term care. They can have their temperature taken. We can take their pulse. They're probably not going to become septic the first 8 hours that you didn't give them that antibiotic. They're probably not going to get septic at all. So, but I think that's a really, really hard transition.
The one area that I'm involved with, I think, is with my dental colleagues. I've noticed that more and more of them are asking us to take care of the prescribing that was alluded to in the previous lecture. I think because they're becoming, at least in my circle, they're becoming more aware of the fact that there's less need for antibiotics. The number of older patients I have who had a murmur, quote unquote, diagnosed many years ago who take antibiotics before every dental procedure. And then I'll even order an echocardiogram sometimes I'm not hearing anything with my stethoscope. I might or might not order an echo, and there's nothing significant. They do not need to be doing that. So I think that the word is getting out. And as a quick aside, I've been working with Major League Baseball for a number of years, and we had a presentation about 4 or 5 years ago by a DEA agent. And the role that dentists played in prescribing hydrocodone and the opiates for any kind of dental work and root canal work was extraordinary. They were accounting for a huge number of the prescriptions. And I think that knowing that, hearing the previous talk, realizing that our dental colleagues, I think, are often left outside of the conversation. And I'm really glad that we're sort of, the tent is getting bigger, and we need to include our colleagues who are in dental practice with education, because they've been part of this whole process.
One thing about the transition, so transition from the hospital or ED to home, when you were in the hospital, most of your antibiotic use is actually in the outpatient side, the prescription you get when you leave. And thinking about duration of therapy is really important. So, we know the adult guidelines for skin soft tissue infections and pneumonia are 5 to 7 days, yet many people are getting 10 or 14 days of prescriptions. And that decision is often made at the last second after a really intensive care in the hospital, and then an intern or another frontline provider writes a prescription that, is either based on 7 or 10 days. So that's this sort of discharge stewardship is really important. And the same thing would be for outpatient parenteral antimicrobial therapy. So, we can put PICC lines in really easily. But when people have done studies, both in adult and pediatric populations, the majority of patients who get a PICC line placed are getting, for antibiotics, are getting inappropriate therapy. So about a third of them need no antibiotics, and then a good proportion of them, about 50% who get them, are getting the wrong choice or duration of therapy. And we know that somewhere between 20 and 30% of everyone who gets sent home with a PICC line comes back to the emergency department with a complication of that PICC line. So that type of antibiotic stewardship at discharge is really important. And people don't always see it because you send them home and you're not the one who sees them come back in.
I think we'll open it up to questions from the audience if there are any.
So my question is, so I cover all the UMP and M Health ambulatory clinics. And so my thing as an infection prevention nurse is that they're all over the place, and each clinic has different physician leadership. Some might use this lab, some might use that pharmacy. And as an IP, I don't even know where to begin the conversation or even who to talk to. Sometimes I'll start with this person who seems really engaged, and that will kind of fizzle out because maybe there's another initiative or measure that they have to focus on. So where do we even begin when there's such a vast variety of people to talk to and different organizations to talk to?
So, and you're talking on the inpatient side or on the ambulatory side? Yeah, it's so hard, right? So I think trying to get small wins if possible, not knowing all the details about your system, but finding, it's unfair where we are because we have this really robust QI system that's really well resourced and a lot of people, but trying to find, interested parties in, frontline providers in those practices that might want to just take on one small initiative, and then talking to them and finding out what are the problems, what are the frequent issues that you have, and if they say, oh my God, it's all about bronchitis, and we constantly have people coming in for that, then trying to find those small opportunities for wins, and then finding out who's got what kind of expertise. Are there people that have IT expertise? Are there people that have done some work in QI and other places and can extrapolate? But it's really hard. It's harder in the ambulatory setting because on the inpatient side, you can go to leadership and find ways to save money. That's the way a lot of inpatient stewardship programs have been developed, because you can save a ton of money by reducing antibiotic prescribing, because the hospital is often paying for that through their pharmacy. But in the outpatient side, you don't always see that return. I don't know if others have comments.
I'll just add that I think champions are huge. I think having a champion identified rather than sort of this loose kind of someone needs to take charge of this, I think trying to find that champion. And then I think that the one common that probably all our systems have is the EHR, the EMR. And if you can sort of figure out how to work that, I mean, I now know if I write for opioids that there's a pop-up, a drop-down, a block, there's something that comes up now, and also the morphine milligram equivalence, pops up, that calculation. That was pretty easy and pretty fast in the big scheme of things, of how fast that came into being. And so I think if we can figure out how to make that work regardless of our system, that could instantly help us the way that it did in Philadelphia.
I guess I'll make a plug for pharmacists. I think that pharmacists play a large role in the inpatient antibiotic stewardship programs. And given that a lot of clinics don't have ID-specific physicians in the outpatient setting at each clinic, I think having a pharmacist be, maybe a point person in addition to your champions, I think that would be a really good use of pharmacists.
And I will just add a plug for, so once you've identified those champions, in terms of enticing more engagement from providers, incentivizing their engagement with things like maintenance of certification credit. So most of us who are in some kind of specialty have to maintain our certification. And so, for example, at the University of Minnesota, we have a mechanism for approving that for our American Board of Pediatrics credit, or family medicine, internal medicine credit. And I think that can really inspire providers to become more engaged quickly. Any more questions? I think there's one over the corner.
So especially as you talk about antibiotic overuse in the realm of things like bronchitis and lower respiratory tract infections, do you think that there's a role for point of care procalcitonin testing and the expansion of that into an outpatient realm? Because, even in the hospital, you're waiting hours and hours and hours, which is strange to me after coming from the University of Nebraska, where we would get it back in 30 to 60 minutes.
I'll use one example. So in the last 2 years, we started doing rapid influenza testing in the office. And I know that it may seem unnecessary to do, but I will tell you, there's been a sea change that when we can have people come in with influenza-like symptoms, tell them within 5 to 10 minutes that they have influenza A or B or neither, that the whole conversation has changed. When people came before, they probably knew they had influenza. We guessed that they had influenza, but the conversation, the length of time it took to tell them why they didn't need an antibiotic for these head-to-toe constitutional symptoms was really challenging. And now it's pretty easy. And if they come in quickly, we may or may not use Tamiflu. But which gives us that thing to do, and we can argue whether that's useful or not. But that has been a game changer. And so whether it's CRP testing or whatever that could help us, I think that point of care testing is probably a direction that we're heading in, and then that really helps change the conversation. I suppose it adds cost on one level, but it's relatively inexpensive, and at the same time, the cost savings from not prescribing antibiotics and the consequences that come from potential side effects is huge.
Yeah, I totally agree. So rapid diagnostics that are clear, like rapid influenza tests, they're getting better and better. They used to be only about 60% sensitive, but there are some that are better. And I imagine in 5 years, your iPhone will be able to test for anything in 10 seconds. But procalcitonin is a little bit more complicated. I think there's some promise there, but just like it's a little more specific than CRP. But the data aren't perfect. I'm aware of 2 clinical trials that are going on right now. I think they're both emergency department based with rapid procalcitonin testing, and they're around pneumonia, right? So there was one that we're it's not a trial yet, we're submitting a grant to do this, but at many pediatric EDs to look and see if there is that proportion of patients that are low risk with, quote unquote pneumonia, who might not need an antibiotic because viral pneumonia is so common. But I think, I guess, I'm not sure I would move forward yet with procalcitonin testing until, one, it gets a little bit cheaper and more available, but two, you have clear guidelines to say, okay, what's the number? And these studies will say, okay, the patient with these demographic factors, these clinical factors, and a procalcitonin less than whatever, 0.5, a study has shown that they're safe to go home without antibiotics. Otherwise, it's a little tough when you get that murky in the middle. And then sometimes you have unintended consequences when you're using a non-specific test, because what if you send it and the value is high, but they look fine? You can, or they look, and then you get, and sometimes that happens. I mean, we see this all the time, and then the unintended consequences might be over-prescribing. So I would wait for clear guidelines around the numbers for that test.
I have a lot, but I'm just going to say two things. So as stewards, one, I know there's not too many of us out there, infectious disease providers, but do you have infectious disease providers on your panel or on your groups? I know my colleague, Dr. Peglow, is going to be speaking later in the out sections later this afternoon, but on each of your groups, do you have ID providers?
So I think, we do have an ID provider. I mean, the sophistication is there, but probably more on the inpatient side and not around outpatient, which involves some element of change management. So there's more than just the scientific basis, there's also the change management. How do we change people's behavior? And so from that perspective, although we have plenty of ID expertise, changing culture, expectation, and plans around treatment, we would need a adoption specialist or something. And I think, at least from my perspective, that's harder to come by.
And then as far as like when I have someone come in for an ID consult, and especially with older patients and asking for dental prophylactic or prosthetic joint prophylactic, I see a lot of prescriptions already set in place at pharmacy that have 999 refills for at Walgreens already, amoxicillin, 999 refills. Oh, I can refill this when I go to the dentist. And then I said, well, you don't need this for your prosthetic hip. This is just not right. Oh, well, I'm here already. I don't need you. My primary care already has this in place. And they already, well, you look like you're 12 years old. I'm going to believe my primary care provider. So how am I supposed to change this 70-year-old guy that has this prosthetic joint as an ID provider, that I'm treating him for his osteo hip infection? That I've only been an IDPA for 7 years. How am I going to change his ideal?
You're right, and the primary care doctor is wrong. So it's the primary care doctor who has to change and then stop the prescription. You can call a pharmacy and discontinue the prescription. So that will be awkward for you to do, but it's probably a call to the primary care doctor. May or may not be a very comfortable call.
I've had that conversation,
but I think, again, that's the adoption specialist that we need, somebody to kind of change people's minds in a way that still, preserves people's, if you tell a doctor what to do, that's not your best strategy. So there is a way to get people to change their behavior, but it's probably not just, let me tell you what I know. and how you're wrong. That probably is not good. So, but there are, I think, strategies, and I think that's one of the questions that you've asked is how do we get to that? How do we change the culture? How do we move to a different place? So I think it's the providers and the patients. It's both.
I have a quick follow-up question for Dr. Gerber. Thank you for the excellent presentation. Could you elaborate on that incentive of financial incentive by the insurance company for appropriate antibiotic use to the providers? I'm curious as to is it based on the diagnosis or the particular antibiotic? And how is an appropriate antibiotic use defined and tracked? Thank you.
Yeah, so I don't know all the contractual details, but it's built into a bonus system that they have, and I don't actually know what proportion of their entire bonus is attributed to this. So I don't know there. In terms of the target, it's specifically for otitis media, strep throat, sinusitis, and pneumonia. What proportion of their patients are receiving the first-line recommended antibiotic, which is amoxicillin or penicillin. And it has to meet a certain threshold, which is based on the benchmark, which keeps changing, of their peers across the practices. And so if they are, and it used to be built at 80%, you leave, we again, within the electronic health record, it's built in, it goes by diagnosis code, and then we exclude patients with allergies, with previous antibiotic use, as I said before. So it does get at patients who when we've gone through the charts and validated, should really be getting first-line agents. But that's how it's constructed. Is that fairly clear? Okay.
Just a question. I don't know if you have any experience thus far with telemedicine in your ambulatory sites. We have implemented a program called Zipnosis, and in approaching this, I just came into my role in February, and so I've been focusing on our acute care side, but our primary care clinics, which are many, are very hungry for help and education and implementation of interventions. With this program, it's not integrated into our Epic system. We just went live with it in November, and I'm trying to figure out how to approach our primary care systems and how much effort to put into tracking down this Zipnosis piece, where they have this very brief tele-encounter with the patient and make an intervention. I don't know if those programs have been in place longer at other sites, or if you're familiar with them, to know whether, I should start there, should I just start with the clinics and general prescribing, face-to-face prescribing. I don't know if those telehealth options are more stewardly, if we even know that, or if they're going to be a bigger pitfall for stewardship and prescribing. I don't know if you even know the answer at this point.
It's kind of a wild west of where healthcare may be going. I'm not totally convinced. I mean, I think Virtual and Zipnosis and all these companies and these options are really intriguing, but it's sort of, for me as a family doc, it breaks my heart a little bit because it's so the opposite of relationship-based care. And I think it really does set itself up for quick access to meds, frankly, for busy working professionals. That's kind of the target audience. You just go online, you type in. And I actually met with the founder of Zipnosis. He's an alum of my college, and we had looked at our clinic being a test site for it. It never happened, actually. And then he was bought out, and it's been very successful. But I don't know if we have enough data yet to know how much we should partner with folks like that. I think that our systems love it as an idea. It's quick, it's got great access, they talk about protocols. It seems on paper like it's a great idea, but I can't speak to its effectiveness and how much stewardship is in place. It's one step kind of between a CVS Target clinic, Minute Clinic. This is more of a virtual version of that, which is very, very protocol driven. So yeah, I can't speak to it more than that. We're at a loss.
I think we have one last question over there somewhere.
both Dr. Meyer and Dr. Hallberg, you spoke about the wait and see approach of how to communicate that. And Dr. Meyer, you talked about it more in the skilled nursing facility where you have the skilled nurses there, and it's this continuity of care in a 24-hour setting, and then reach a provider at any point in time. Dr. Hallberg, you kind of talked about it more with like you actually give the prescription to the patient and say, fill if your symptoms get worse. And I just wanted to have you two kind of talk about the nuance of that, and then also wondering if the second option in a more ambulatory setting is based on just our breakdown of healthcare of this Monday through Friday, 8 to 5. It's coming up on a weekend. I'm not going to get my regular primary, so here's a prescription and talk to me on Monday kind of thing.
So I think it goes to that monitoring piece, and I don't know if there's any other way to do it other than to, at the end of the appointment, and I do it in outpatient a lot too, recap and say, we'll call you tomorrow. So we have team-based care in our ambulatory setting, so it's very easy for me to send a message, and I know that one of the nurses on the team, who the patient may in fact know, will call tomorrow and check in and get a hold of the person. And just knowing that somebody's going to call tomorrow is helpful, I think. And we're able to pass that on and do it Saturday and Sunday. So I think that's kind of an old-fashioned concept, but I do believe patients value it. And if you're trying to get out of the room without writing the prescription, you have to have some exit line. And I think that's a pretty good one.
So we have really high MyChart use in my clinic. About 80% of our patients are assigned for MyChart, and I think it accounts for a lot of our patient satisfaction. Patients are astonished how often and how fast I respond to them. Sadly, that's sometimes on the evenings and sometimes on the weekends. I mean, part of it, I hate in-basket stuff, and so I want to take care of it, and my patients know that and take advantage of that a little bit. And when I literally write a wait-and-see prescription, possibly print it off and hand it to a patient, this is someone I've known. You know, it's not a brand new patient. It's someone I have a relationship with. I'm going to be out of town, and we have team-based care, and we'll follow up with them. And the reason I adopted that was that Brad Benson at the University a number of years ago quoted some statistics and studies out of Scandinavia and the effectiveness of that and how few people actually use them, especially for antibiotics. And so that kind of convinced me that in the right context, not for everybody, not for the person that looks like they're desperate and they want something in hand, but people who are very reasonable and maybe have had a history of something, you know, a sinus infection that really did go on for a month, it was CT proven and required intervention, you know, but they're not there yet, you know, I might do something in that case. So I should really add that it's very contextual, and it really is sort of a case-by-case person that I might do that with.
Okay, thank you to our panel members.